Hi, my name is Anaís Troncoso, and this is the presentation for my week 2 SOAP note for FNP 597. The ID for the patient is patient ML. She is a 34-year-old Hispanic female with a date of birth of 01/01/86. Patient is married. The patient is presents with the chief complaint of concerns for infertility and pelvic pain. Patient is a 34-year-old patient with complaints of concern for infertility. She has been attempting to conceive for over the last year. She's accompanied, the failure to conceive has been accompanied with dysmenorrhea, painful intercourse, and pelvic pain. That the patient rates at about 6 out of 10. She says the pain is intermittent. There is nothing that triggers it or relieves it. It is just there throughout the day in intermittent intervals. The patient states that she feels emotionally distressed at times but has no suicide ideations. This has been going on for the last year as well. The patient denies any dysuria, flank pain, hematuria, diarrhea, constipation, fever, chills, nausea. As far as the pertinent medical history, the patient states that she was told in 2018 by another provider that she had a pelvic mass. Other than that, there is nothing else pertinent to the medical history. Upon assessment, the patient is a well-groomed, well-nourished female who is able to sit upright on the examination table. Then we went ahead and all other systems were normal. But pertaining to the case, the patient presented during the pelvic examination, as I mentioned, the gastrointestinal and urinary were all normal, except for upon the pelvic examination, the patient did complain of pain during the pelvic exam. Also, she did state that she did demonstrate more of a flat affect of sadness. As part of our diagnostics, we went ahead and we did a transvaginal ultrasound with my OBGYN preceptor. This demonstrated ovarian endometriomas, or chocolate cysts, he called them. As part as their differentials, we went ahead and I came to the conclusion that along with the patient's symptoms and diagnostic findings and physical assessment findings, that the patient is presenting, our first differential and primary diagnosis is endometriosis due to the patient's symptoms, assessment, and diagnostic findings. My second differential diagnosis would be pelvic inflammatory disease, but this was ruled out because there was no fever, nausea, or malodorous discharge during the pelvic examination. The other differential would be irritable bowel syndrome, but this was also ruled out because there was no changes to the bowel habits, no reports of diarrhea or constipation. It was just the lower abdominal pain, and which the patient would call as pelvic pain. As far as our treatment, we will go ahead and start the patient on Orliza, which is elagolix, or at 150 milligrams once daily, so a quantity of 30 with one refill. This will be primarily used to lower the estrogen levels causing the endometrium pain. Then we would also use Danazol, which is 200 milligrams twice daily, so that would be a quantity of 60 pills with one refill. This is used primarily to help shrink the displaced uterine tissue. We would also prescribe ibuprofen 600 if needed every 6 hours for the pain. And we would let the patient know we are planning for a possible laparoscopy and MRI for further diagnosis of endometriosis. We would also advise the patient to decrease or hopefully abstain from consuming alcohol or caffeine in order to help alleviate with the endometrial pain. And we would see the patient for a 2-month follow-up to see how she's responding to treatment, and to further consult on the future plans for laparoscopy. And this has been my case. The references will be listed in the discussion post below. Thank you.